Good afternoon in Africa, good morning in the US, and welcome to our monthly Africa-U.S. Forum. This month, perspectives from the continent, responses to reductions in global health assurance assistance from the United States, Europe, and others. This is the third of our quarterly dialogues on the future of Africa, U.S. health diplomacy. This forum is on the record and is being recorded. Video will be available later on our website, along with the video of all of these forums that we've been holding every month. Our next Africa-U.S. forum will be on Monday, October 27th at this same time. These monthly forums are presented by, in alphabetical order, the African Center for the Study of the United States at the University of Witwatersrand in Johannesburg, the Annenberg Center for Communication, Leadership, and Policy at the University of Southern California, Center for African Studies at Howard University, the Institute for African Studies at George Washington University, the Institute on Inequalities in Global Health at the University of Southern California's Keck School of Medicine, and the Public Diplomacy Council of America. Now we go to my colleague who has done so much work on these Africa healthcare programs and forums, and so much work on the ground in Africa. Jonathan Cohen, Director of Policy Engagement for the USC Institute on Inequalities in Global Health, and a clinical professor for the Division of Disease Prevention, Policy, and Global Health at the Keck School of Medicine. Jonathan, the floor is yours.
Thank you. Thank you very much, Adam. Thank you, everyone, for joining us. Good morning, good afternoon. We're very pleased to be gathered for the third installment of a four-part series that we're doing this year on the impact of the sudden withdrawal of U.S. aid on health in Africa. This is a series that features all African voices and experts on how the continent is reacting to this withdrawal of aid, what the early signs are of the public health impact of the withdrawal. And today we will discuss the issue of adaptation, how it is that the many hundreds of health implementers throughout the continent are adapting to the withdrawal of aid, both in the immediate and in the longer term. We are fortunate to be joined, as usual, by a very impressive lineup of speakers. I will introduce all of them to you. Our colleague Judy Kang will put their full bios into the chat, and then we will have a conversation with them for about an hour. We'll then open it up to questions. And then at the end of the panel, we have a special feature today where we will be introducing an inaugural cohort of USC senior fellows in global health communication leadership. This is a new program that we are launching today that accompanies our monthly Africa-U.S. dialogue series and gives leading public health experts on the continent an opportunity to affiliate with us at the University of Southern California to use innovative journalism and communication strategies to amplify neglected public health issues on the African continent. So please stay to the end, and you will be treated to an introduction to our four inaugural fellows following the conversation about the impact of the U.S. aid withdrawal. So to guide us in our conversation about how Africans are responding and adapting to the withdrawal of U.S. aid, we have four speakers today. And as I said, I'll introduce all of them. The first one will be Alfred Akerele. Alfred joins us from Nigeria, where he is a grant analyst at the Nigerian Economic Summit Group, supporting high-impact projects through grant proposal development, donor relations, management, and policy compliance. And again, you can read his full bio in the chat and his many impressive achievements. We will be joined, I don't know if he's logged on yet, but we're due to be joined by Dr. Etukoit Bernard Michael from Uganda. Etukoit is the executive director of the AIDS Support Organization Uganda, or TASO Limited, where he has served for the past 10 years. He has led major initiatives, including developing innovative care models such as home-based care, with retired health workers. Tasso has been around since even before the scale up of US aid and has been a leader through the many years of the President's Emergency Plan for AIDS relief. So it will be very powerful to hear from him. And then our other two panelists are, in fact, two of our inaugural fellows in global health communication leadership. So wonderful to see the overlap between the program and the fellowship. One of them is Mia Malan, who you may have seen before in a previous session of ours. Malan is the founder and editor-in-chief of the Bhekisisa Center for Health Journalism. And to that role, she brings significant experience working in newsrooms in Johannesburg, Nairobi, and Washington, D.C. She is an award-winning broadcaster and editor, and joins us en route home to South Africa from the United Nations General Assembly today. And last, but certainly not least, we have the Honorable Ben Malunga Phiri joining us from Malawi. Honorable Phiri was just re-elected to the Malawian Parliament and is a candidate for Parliamentary Speaker in Malawi, and also acts as president of the Eastern and Southern African Parliamentary Caucus on sexual and reproductive health and rights and population and development, and has previously served as a minister in the Malawian Parliament. So a very impressive panel, as you can see. So I'm gonna start with a question for all of the panelists, and perhaps we'll go in the order that I introduced you. We'll begin with Alfred Akerele. We'll then move to Mia Malan and then to Ben Phiri. My first question for you is, being on the ground in Nigeria, in South Africa, in Malawi, in Mia's case, doing extensive reporting on this issue, what are the early signs of adaptation are you seeing, that you're seeing in response to the recent unforeseen withdrawal of US aid? How are organizations, societies adapting so far? Alfred, over to you.
All right, so thank you, Jonathan, and it's nice to be here. Could you please confirm you can hear me?
Loud and clear.
Great. So thank you so much, and once again, I mean, it's from the background, it's going to be an interesting conversation. So I'm happy to be here. So to your question, the early signs of adaptability. I mean, the reality is here. It's no longer a dream. It's a reality that every organization, facilities, and every other companies that have a bit of funding from US, either USAID, the CDC. I mean, all of these organizations. It's a reality that we are facing. So the first level of adaptability, which are the early sign, is one, the reality is here. Two, diversification is now a statement of fact. I mean, funding diversification is now a statement of fact, and a lot of countries, a lot of organizations, regardless of your thematic area, I mean, focus on health, financing, and every other sector. Diversification is the first thing that everybody is now thinking of. So USAID is gone. What next? I mean, there are interventions that needs to continue. There are activities, there are programs, there are initiatives that needs to be sustained. So the first early sign of adaptability is diversification. And I mean, finally, for me, which is one of the most important early signs, is modification of programs activities. Right? So a lot of organizations are now thinking of, okay, so what can we do to support what we are doing before, and how do we modify what we've been doing before to meet up with the current reality of the drop in development financing, health financing across different interventions. So these are the early signs. I mean, there are negative signs of facilities shutting down, drug medications not being made available. I mean, all of these negative signs are there. But I mean, in terms of profiling solution, now those are the first, signs that we've been seeing across different countries, different health intervention program. Thank you, Jonathan.
Thank you. Thank you, Alfred. So, early signs of modifying programs, of attempts to diversify funding sources. We'll look forward to hearing some examples of that later in the program. Mia Malan, what has Bhekisisa's reporting revealed about adaptation so far?
Yes, thanks so much, Jonathan. So I think the first thing we saw in South Africa was integration of services. So we saw the government taking over services that was previously funded by PEPFAR, that was mainly for key populations, so groups of people with a higher chance of getting HIV, like sex workers, like people injecting drug users, like transgender people. It hasn't been without problems, because you could imagine that people now face long waiting queues, and there are many health workers who aren't specifically trained to deal with those populations. The second thing is we want to see more domestic investment in the long term with this crisis, and we've seen some of that in South Africa. In May, our government announced extra funds for the health department from a general emergency fund for departments in crisis. And I know our health department is consistently negotiating for a bigger budget for next year. The other interesting thing that we saw as part of that investment was two donors, the Gates Foundation and Wellcome Trust, announcing different types of grants, and those were co-investment grants. So they said, we'll invest in you, especially for research when it comes to HIV, but only if you give 50% of the money, where previously we received all the money. So there is definitely a change in how donors are starting to invest. The other changes relate a lot to strategy. In how you roll out HIV programs to do it with fewer resources. And the first thing of that is 6-month dispensations. So having a different way to give out ARVs, to give it for longer periods to people for 6 months at a time, so that someone only has to come to the health system twice a year, because that will reduce the burden on the health system and also on patients to, when it comes to transport costs and those sort of things that were often previously funded by the US government. We've also seen some investment in data capturers. The health category that the US government invested the most in when it comes to health worker job descriptions in South Africa was data capturers. So people who would be working with nurses and doctors and record how many people get ARVs, who's not coming back, who do they need to go and look for. And 40% of our data capturers were funded by the US government. So we're starting to invest in that. And the other very much talked about program that the government is starting to invest in, so that there is a lot of investment in prevention specifically, is the rollout of a 6-monthly injection that can prevent HIV. We have some global fund money to roll it out, but not nearly enough to put the millions of people that we need to put on it to make a dent in new infections. So our government has these early indications that they would be prepared to also invest in generics with their own money in 2027 when they come to market. And of course, last week there was a huge announcement by the Gates Foundation and Unit 8 to say that they will work with 2 generic companies to make that injection available for the same price as a daily oral pill. So those are some of the strategies that we have started to roll out.
Thanks, Mia. And Ben Phiri, look forward to hearing from you, particularly because South Africa, which Mia has just described, is obviously a very particular context, certainly a wealthier country than Malawi. I'm curious what you're seeing, and if you could comment in particular on any similarities or differences between what you're seeing in Malawi and what Mia just described in South Africa.
Thank you very much, Jonathan, and all other participants to this important conference. To begin with, let me say that this has come as a shock to us, a shock, and surely it will not be easy, no matter what strategies we put in to recover in a short period. It will take us a bit of time because of a number of issues. Number one is the size of our GDP. And again, elite levels in Malawi cannot be compared with others. If you look at the GDP of Malawi versus that of South Africa or Nigeria, you will notice and appreciate what we're talking about. Again, poverty levels are so low. I mean, there's been a time when we were, I think, a Malawian would really live below 50 cents, and that's not easy at all. Therefore, quite a lot of issues are affected within the health sector: HIV and AIDS, drugs, sexual reproductive health, and its commodities, contraceptives, and everything. The outcome means, therefore, that we may not have contraceptives available in hospitals, and we've got a massive, actually rapid population growth in Malawi, which provides then competing priorities, competing demand for drugs, commodities, and everything. But it has happened. It is here with us to stay. What are the early signs? A number of issues that we have tried to do. To begin with, let me say that we have got a robust community health system that is manned by what are called health surveillance assistants. I believe that this is not common in many parts of Africa, but we've got a robust one in Malawi. And what we've done now is to equip these health surveillance assistants, because they are found in the communities. They live with the people. They will live probably 20 kilometers away from the hospital, but they have got basic essentials for first aid and all sorts of things. So we have now deployed a strategy to have them equipped to venture more into prevention. So now we are encouraging them, for example, for non-communicable diseases like BPs, sugars, and everything, to begin to encourage our people into exercises and others to make sure that at least whatever we can prevent, that we should go down to it, dive into it in a serious manner. We have as well initiated a series of strategic reforms to make sure that we improve in terms of efficiency and to ensure a continuation of services within the products that we have. Otherwise, there was a lot of wastes when all was well, but at the point in time, we can't afford to have wastes anymore. So we have put together a robust sort of system that will improve efficiency. Among others, as my colleague from South Africa has indicated, we have adopted a 6-month sort of drug administration. That therefore would mean that the defaulters will be minimized, because oftentimes you would find that drugs were expiring in the hospitals because on the month-to-month basis, people could not come and pick them. But with this new arrangement to make sure that at least we administer the drugs, at least a dose enough for 6 months, it has improved quite a lot. And then we have adopted as well a one plan, one budget, and one report. What we're calling one plan, one budget, and one report. In this one, what we're doing is a number of partners that we're funding different healthy commodities and services now are getting together to put up one plan. So some of the programs that were being run, for example, by USAID are now, and other programs funded by different partners are now put together to put up one plan. And then we are saying one budget. So as long as, say, for example, it is HIV and AIDS drug administration, all of them will put them together and they will run on the same budget. And then when reporting, it will be one report as well. So those are some of the clear indicators that the government is really ready to adopt. I must indicate on the onset, it is not easy to do that because of the rapid population growth, the size of our GDP, the poverty levels, all that together poses a challenge, but we have engaged in extra gear to make sure that we adapt. Thank you.
Thank you all. Before I get to my next question, I'd like to ask any of you who wishes to comment on a follow-up question I have that I imagine many in the audience are wondering about too, which is that many of the adaptations that you've described, whether it's diversifying funding or integrating services, mobilizing domestic resources, investing in long-acting HIV prevention, encouraging healthy behaviors, integrating strategies and budgets, all of these sound like good things and like things that perhaps are long overdue. So I guess my question is, recognizing that these are in some ways positive developments and also that what precipitated them was a sudden and shocking withdrawal of aid that has also caused immense fear and suffering. Is there any way that these positive adaptations could have occurred without the United States having suddenly withdrawn its funding? Would any of you like to comment on that?
Right, maybe I could start. Ben here. Let me say this, that the withdrawal is a blessing in disguise in a way, because I'll tell you what, I believe a government must be able to provide resources, must be able to provide services to its people. Honestly speaking, the over-dependence on the donor partnership really did push us into a complacency level. In Malawi case, we had started for example, the National Health Insurance project a long time ago. But time and again, because we kept on getting these fundings, we kept on postponing it for political reasons, and what happened later, we were too much dependent to donor aid. So to answer your question, were they going to be initiated? Were they going to be actioned? The answer is yes, they were going to be actioned, but this has helped us quite a lot. It has pushed us into the corner without any choice. Unfortunately, if we had started ourselves, we would have had the proper implementation plan and have an exit sort of strategy as to when we will win ourselves out of it. This time around, we've just been pushed into the pool when we are not able to swim. So we can't swim, but we must survive. Thank you.
Thank
Jonathan?
you. Yeah, after you, Mia.
So,
yeah. Mm-hmm.
I think I can add to what Ben says. I don't think the US government made us do things that we would never have done. I do think all crises speed up processes. We saw during COVID with vaccines being developed quicker. We saw public-private partnerships during COVID happening much quicker than ordinarily. And I think that is what this crisis has done. It has sped up solutions. South Africa, for instance, we were always going to do the 6-month dispensation of ARVs, but we were moving very slowly. So this sped up the process. But what this crisis, the damage that it's done is that no one was prepared to do this overnight. And the proportions of people who have fallen off treatment or who don't have access to HIV prevention at the moment, because this was done so quickly, has had devastating effects in terms of increases that you'll eventually see in new HIV infections because people are not on treatment, because there aren't HIV prevention as there was previously. So I do think the lesson is, yes, crises always speeds up processes, but doing it this way also has very long-term consequences, even though it speeds up solutions.
Alfred, would you comment on
So,
that?
so,
Mhm.
yeah, so just let me add to the two speakers. So one of the things we've seen that with or without funding, the reduction or cuts, the entire cuts, diversification is very important. And one of the things, like Mary said, I mean, this is just a wake-up call for governments, to take up responsibility. There was a 15% health budget allocation advocacy to, I mean, countries within the Africa continent many years ago. And this, I mean, it was an Abuja declaration, and this has not been followed. The over-dependence, the over-reliance, for donors to come, I mean, Gates Foundation coming, USAID is coming to do something, Gavi is coming to do something, UNICEF is doing something at the other end. I mean, this over dependent has really weakened the system and has not allowed the government to take up to the responsibility, and has not allowed some of the health facility to be a bit conscious of the fact that, I mean, this is not government money, this is not government funding, it's purely donor funding, and it should be done in a way that help the citizens to benefit adequately. And, I mean, a mutual understanding of the process to all of the funding that is being gotten from donor related. So it seems to be more of blessing, more of wake-up call, more of action from the government and from the facility managers, and I mean all the stakeholders within the health sectors. Yeah.
Alfred, thank you. And while you have the floor, let me ask you my next question. You of course have mentioned a couple of times efforts by former USAID recipients to diversify their funding. And you indeed are a resource mobilization consultant. You sit with these organizations and help them do that. Can you give us a sense of what funding diversification strategies you're seeing? What sources of revenue are organizations seeking that they perhaps might not have sought before, and how successful do you think these strategies are so far and will be?
Okay. So thank you, Jonathan. So when you talk about funding diversification strategy, I mean a lot of organizations that were really affected. It wasn't just because they weren't prepared. It's just for me as a result of a bit of complacency. And now that it's happened, so many organizations started by thinking of donor mapping. So should we now map out more donors that are able to support the kind of work we're doing? And from that, build a very strong donor intelligence report, or deck, you want to call it, to help them understand what are the priorities area of other donors. So if you talk about the European Union government, of support from the EU, either directly from the EU organization or some private philanthropists within the EU or from the US. I think I've mentioned Gates Foundation, MacArthur Foundation, Luminate, and all of these. So now we need to do a sit-down meeting to understand what are their priorities area. And that is one of the things that has been missing before now. You see, everyone applied to USAID, and before 3-4 months, you're gonna get a response that, oh, your grant is this and that. So it's really donor mapping now expose other opportunity. And one of the other thing that I've seen, I mean, in my work with organizations across Africa right now, is the fact that every organization are now looking inward to exploit some corporate partnership, right? So we're leveraging corporate social responsibility from corporate organizations. So if you have organizations that are working in your country, then you can tap from their corporate funding, and it supports the kind of work you do, not as large. So the unfortunate thing is that all of this funding are not always as large as what you're getting from USAID or from CDC or any other organization from the US. But this diversification has exposed to other means of leveraging funding. I talked about program modification. So the courts also help organizations to modify their programs and introduction of tech. So what can technology do? I mean, some of the things we do manually, can we bring in some technology that allows us to do? And at the wake of COVID-19, many organizations, companies in Africa desire, I mean, there is a quest to manufacture vaccine, right? So beyond all of those quests to do all of these things, there are introduction of different things that makes it very easy for them to do the kind of work they do, right? So it's pretty important that now we've seen high level of intelligence around donor mapping, high level of intelligence around developing deck that allows to have sit-down conversation. And for some couple of consulates or embassies within the continent, organizations are now approaching, having advocacy meeting, having sit-down conversation to say, oh, this is what we're doing. We have been affected by funding cuts. Can you assist us? Do you have initiative like this? Is your priority area in this direction? Can we partner together? Can we collaborate? So it's really exposed, and majority of the organization now invest in building fundraising team, right? So I mean, an entire department in an organization that allows for this work to be seamless, that they do the research, they do the writing, they have the conversation with prospective donors, they reach out by email, do a lot of works that now bring more strategies in place for diversification. Yeah.
Thanks, Alfred, and look forward to an opportunity to learn more about that. And also just want to remind the audience that there will be time for questions following this conversation, and you're welcome to enter any questions into the chat as they come up for you. Ben Phiri, let's come back to you. You are, of course, a regional leader in the field of sexual and reproductive health and rights. And I'm curious about this sector because on the one hand, we know that USAID supported family planning and contraception and various reproductive health efforts, but we also know that there were very stringent conditions on US funding in this area, such as the so-called anti-prostitution pledge requiring grantees to have a position against prostitution, and of course the global gag rule prohibiting any grantee from saying or doing anything, even with their own funds, to promote or facilitate abortion. So given that kind of mixed record, how do you see the sudden withdrawal of US aid affecting the sexual and reproductive health and rights sector?
Well, thank you very much. I know for a fact that the GAGO and all these restrictions that USAID and others had really did affect the drive in the sexual reproductive health and rights, particularly in our region. The reason was simple. For example, you'll find that most of those that required these commodities falls within the same grouping, prostitutes and all sorts, but then their money was not supposed to venture into that. And then you find a situation, I'll give you a good example of Malawi, where the abortion, there was a time that one of the members of parliament wanted to table a bill in parliament to do with the abortion. But then advocacy to the same was not done. There was no he did not get down to consult the chiefs and others, because in Malawi, in a way, it is a taboo to talk about abortion and others. But the question was, is this matter affecting them on the day-to-day lives? And the answer was yes. Now, how affected are we now? I can assure you, in as far as this is concerned, particularly that sector, not much has been lost, because there were only one or two organizations who really were free with their money to dive down into this. I know in Zambia, I know in Malawi, I think there is one organization and two, but they did not have much resources to deal with these embargoes and restrictions. They did not care about these restrictions. As such, you will find that there were not many positive strides that were made in the same. But that said, we were still doing our own traditional way of addressing the same. One of which was traditional engagements with the people there to understand that some of these things like abortion, for example, we tried to change just the languaging. For example, in Zambia, the abortion, I will give a good example in Zambia of the comprehensive sex education, which was not in any way unsupported on the other side. We were able to change that into healthy living subject, and it passed within the curriculum in Zambia to the extent that now it is. In Mozambique, they called the same. They changed from abortion bill, they changed that to abortion management bill, and it passed as well. So it helped us in a way to be innovative and be able to come up with other words of dealing with the vice, but in a manner that at least it is we still achieve what we wanted to achieve. So to really lap it up is that yes, the funding is gone. The restrictions that were there are no longer there, but of course they were attached to the funding, so not much has been affected. But the ones that now were helping us in this particular area now are upscaling to make sure that at least we manage that, because most of the programs there were more preventive, and they were reducing the appetite, the demand to consuming the very product that the same organization that were restricting were opening. So the demand that was being created there was being managed by the very organizations that were supporting the same. So in a way, it is a bit of an imbalance that the demand now, because the demand now will now get increased because of the same. Thank you very much.
Thank you, Ben. We have a question that I think is somewhat related to this from Adam Clayton Powell. And the question, and I'm gonna start with you, Mia, and then invite Alfred and Ben to come in if they wish. U.S. Secretary of State Marco Rubio recently said, and we can see this in the new U.S. Global Health Strategy, that any future U.S. assistance to Africa will be directed primarily to African governments through these new global health compacts, rather than to non-governmental organizations. If that indeed happens, would that be a change for the better or a change for the worse?
You know, Jonathan, that is a question with an interesting answer, because as you may recall, the US government used to give money directly to African governments, and then about 10, 15 years ago, they started to argue there's too much corruption. They're going to give it to non-governmental organizations to do the work of government, basically, because they felt there would be better control over the money. Now, obviously, for the long term, one of the longer-term sustainability solutions is to address corruption and to look at things like debt relief rather than just looking at more funding, because everyone is reducing their funding. The Global Fund, the UK, we've seen it everywhere. So would it be better? Well, we would certainly hope that it would increase the government's capacity to do things better. In South Africa, for instance, the government does do most of its own work, but it did in the HIV world start to rely on things like serving key populations very much on NGOs, that you really got NGOs that did the government's work for it. But we cannot give money directly to governments if there aren't proper strategies in place to allow that money to be used for what it's supposed to be used. So I would imagine that if that happens, there would be requirements from the US government to see that there are proper corruption fighting strategies in place.
Thank you. Alfred, Ben, would you like to come in on this question?
All right, so
Yes, probably.
let me come in. Okay, Ben, go ahead.
All right. As speaking as now a government official, a politician, whether it will have an impact or not, I'll tell you what. Through this cut, we have now, as governments, and I am not only speaking about Malawi, but the region that I chair, governments have now come and reorganized itself with the non-government organizations that are operates in the communities in what I have described a question before as one plan, one budget, and one report. That is to make sure that there is accountability, effectiveness, efficiency, and making sure that nobody is left behind. Because what was happening was a lot of misfiring. A different organization doing a lot of things, spending money, and it was not helping anything. When it comes to non-government organization at country level, they were not, in most cases, answerable to the government. And I know the mischief that the current US government is trying to manage is that of political conniving, where part of the money that would come to Malawi would not necessarily all ends up in Malawi, but would end up hanging somewhere before it gets into Malawi, which was, as a politician, which was aiding some people to get into politics. So in a way, yes, it will help governments, but governments needs to be capacitated enough to, among others, be able to trace corruption, as Mia has indicated already, to trace it not after, but probably preventive, and be able to capacitate its people to curb corruption and get down to it before it completely happens. Otherwise, any penny that gets lost within the system surely will affect somebody, as it is already affecting now. Will the government be able to spend this money alone? Because at times in other countries, absorption is low because of bureaucracy and everything. That is where now, probably at government level, it will now have to put up programs that will corroborate with the different players now, the non-government organization, that will now go on the ground and begin to implement. But who gets the money? The government must get the money, because then with their own resources, they will be able to allocate them properly to these non-governmental organizations as implementers, and those that will account for the money going up. So it will be top going down than what was happening, that civil society organization gets the money, they implement anyhow without at times even following the government policy, and then they don't even report to the government, the money disappears, and then it goes. This time around, the government will be responsible. I thank you.
Go ahead, Alfred. Thank you, Ben.
All right, Ben, thank you so much for your last comment, and I'm going to pick it up from there. So the advantage of the statement, I mean, if governments will now be the direct recipients of funding, one of the advantage, I think, that we address. I mean, there are other negative effects that has been mentioned by May and Ben, I mean, around corruption. But I think one of the things that we really address is the willpower of the government to be able to have a better grasp and understanding, and that's alliance programs with policy of the government. I mean, different governments with different policies. So one of the missing link that we find out over the years for organizations that implement projects in Africa is the fact that majority of them implement programs without government consent, or without bringing government into what they're doing. So why government is doing A, B, C, I mean, the NGOs are doing another thing entirely. And of course, to now get the legislative will of the government is going to be very difficult. regardless of how powerful you are as an organization in any country, you need some legislative backup to implement whatever policy you are pushing for. So if the government are not included from the start, that is not going to happen. So I think that is going to address that. I mean, now bringing the government into it, having strong legislative backing, developing stronger policy that will best solve whatever intervention or activities you're doing. So the part of corruption can really be solved, and I believe there are strategies that can be put in place to checkmate that. It's work in other sectors. And I think if that is properly done, it's going to work. My only fear for that is I mean, for instance, if the government is not in true alignment with the US government, what now happens? I mean, the entire people is just going to die off, and you're not getting anything. So while it has its own advantage, but I mean, there are a couple of disadvantages to it. Yeah.
Thank you, Alfred. I do see the additional questions coming in from Washington, and we will get to them. I want to shift gears for a moment, come back to you, Mia, and engage you on one of the most important public health issues confronting the continent right now, in the middle of which this withdrawal of aid occurred. And that is, of course, the health effects of climate change in Africa, an issue that you have done quite a bit of reporting and writing about. Of course, we know that extreme heat, weather events, drought have huge population effects in terms of food security, respiratory disease, other chronic conditions, access to health care. I'm curious, you've done quite a bit of work on this, how you might see a withdrawal of U.S. assistance directly or indirectly affecting this and affecting African governments and countries' capacities to adapt to climate change.
Yes, Jonathan, as you've mentioned, we hear so often about the health effects of climate change, but we mostly hear about what happens to people when they're exhausted from heat, or, what happens when you've been in a flood, cholera spreading and stuff. But what we don't hear so often about is what effect will it have on HIV and TB? And the short answer is climate change will make HIV, TB, and also non-communicable diseases like diabetes much, much worse. And that is why fewer resources to address those illnesses that will now become more common would have a devastating effect on it. And here is why climate change will make HIV and TB and diabetes worse. So if you look at the effects of drought, one of those very obvious effects is that people will lose their livelihoods. And in poorer countries, those livelihoods are so often subsistence farming or running small shops. Now, as soon as you don't have people to buy the stuff in the small shops and you can't provide food for yourself, one of the things people so often then rely on without any other option is transactional sex. And then you end up in a negotiation, in unequal relationship where one party has all the negotiating power. And that is why in the context of transactional sex that are likely to increase during those times, you will see HIV new infections becoming more common because of these relationships increasing. But in addition to that, when you have floods and long-term droughts, which we will see more of because of climate change, you have mental health effects and you see depression and anxiety increasing. And there's lots of studies that show us that when people are more depressed and anxious, when they need to take chronic medication like antiretroviral medication, which needs to be taken every single day, they are less likely to take it consistently. Now, we know that HIV treatment keeps you healthy, but in addition to that, it also prevents you from spreading the virus if you use it consistently. So it's both it's treatment, but it's also prevention. As soon as you see people starting to use it less often, then you're going to see more HIV spread, and you're going to see more sick people, which will put a burden on the health system. In addition to that, there is a lot of research showing that the most common illness of people with HIV who are untreated is TB. So if you then have more untreated people, you're going to see more TB. And that TB is not just going to spread to people with HIV, it's going to spread to everyone. And worsening that even are things like when there's a flood, people lose their homes and you put them all in a community hall, and that is ideal for the spread of TB. Lastly, there's research showing us that if you have TB, you are more likely to develop diabetes, and the same vice versa. If you have diabetes, you are more likely to develop TB. So you can now see if you have more HIV, more untreated HIV, you have more TB, you have more diabetes, it's really a snowball effect. So fewer resources for these diseases mean a devastating consequence for all of them.
Thank you, Mia. Ben, I'm so curious if you're seeing these dynamics in Malawi. I remember seeing research, for instance, that drought in Malawi was impeding people's ability to travel by boat to get their HIV treatment. A perfect example of what Mia is describing of how climate change can affect HIV treatment adherence, which can go on to increase TB and then other chronic disease risks. And now, just in the middle of this, the government has fewer resources to deal with HIV and TB. Can you comment on that from your local perspective?
Thank you very much, Jonathan. I can't agree more with her. Within the space of sexual reproductive health and rights, one of the pillars that we decided that we were going to discuss and zero in was the relationship with climate change, because we discovered that it was really, really affecting us big time. You're right, there are places where traveling is only by boat, and you find that when it hits, these people cannot access anything, and it doesn't really help. Not only that, we've got a place in the lower Phiri, the lower part of Malawi, Chikwawa, Msanje, which time and again overfloods. And once it does, we'll find that within the emergency plan of our country, the issues to do with sexual reproductive health, HIV and AIDS and everything are not included. So the intervention that takes place there, you will find that probably food interventions, shelter interventions, and all sorts of things. But when it comes to drugs, nothing is incorporated. Those that are affected by HIV and AIDS do no longer have got their drugs because they would have left them at home when these floods and everything were happening. What about women that are within the periods? They don't have pads, they don't have nothing. The commodities are not there, and then the women are abused and everything. So you cannot in any way around separate issues of climate change to that of the subject that we're talking about. Malawi is a good case study. I know of Mozambique, where women under those critical moments of effects of climate change were harassed and everything. They couldn't even get morning after pills. They couldn't even get their HIV drugs and everything. So obviously she's right, and I can't agree more. Malawi and indeed Southern and Eastern Africa gets affected by the same, and we as governments must up our games to make sure that even in the disaster preparedness plans, we incorporate some of these issues as she is putting across. Thank you.
Thank you. And one of the questions that's just come up in the chat, I think, is directly relevant to comments that you and Mia have been making about both climate adaptation and sexual and reproductive health. And I want to extend this question to each of you as well as to Alfred. And this audience member has asked whether any of you has noticed specific mitigation or resiliency strategies being employed by women in your countries. and communities. Women typically lead efforts during any crisis, such as burden sharing or leading community efforts to find new resources. Are there particular examples of women-led adaptation strategies that you're able to share? Ben, you have the floor. Why don't we start with you?
Thank you very much. I will give you the experience that we noted when we heard of a flooding in Chikwawa, and the traditional, well, for example, pads and sanitary, all the sanitary equipments were not there. They deployed their own means, and I can assure you that those Malawi, we've got a few Malawian women here, they traditionally, the locals do have their traditional ways of managing the same, and I'm proud of them. Unfortunately, it lacks a bit of hygiene, which leads to quite a number of problems as well. Because as far as they're concerned, they will get the clothes and do whatever they want to. They know traditionally how they package that to help themselves, but it does not stand the minimum standards of hygiene to really guarantee that they will not be getting infections and everything. So if you ask me, have they deployed any of these, I would tell you that yes, and I have never seen women like those of Malawi and the Southern and Eastern African, because they're very creative when it comes to these things. I'll tell you this. We grow, as we're growing up as boys and girls within, even in those situations like the ones I'm referring to during floods and everything, you will not notice in any way, in even a minute, that our women are affected big time, unless you're an expert in the field, because they have deployed a means that really gives dignity to their women's health, and they find their own means of making sure that, because it is more or less like a taboo for a man to notice that these women are passing through these difficult times in our society. There is that stigma, there is all that, and the women are so resilient to the extent that they're able to get down to it. But that, to me, is not good enough, because it doesn't guarantee the minimum standards as required by our health standards. So yes, it is. Thank you. That's one example that I would give.
Thank you, Ben. And I'm sure there are many more. Mia, any examples come to mind?
Jonathan, yes, they're not specifically women-led, but they are for women. So our government has an app for pregnant women called Mom Connect, and that app reminds you of gives you pregnancy advice and those type of things, and it reminds you of your clinic visits. And last year they added a part of this app to focus on giving pregnant women warnings when there are floods ahead of times, when they would be, because if a pregnant woman gets stuck in a flood, especially in the later stages of pregnancy, the chances of stillbirth increase quite significantly, and complications for birth. So that's one thing. The other thing is, in Namibia, about 2-3 years ago, the Namibian government started to, when there were floods, when they saw warnings of floods, they started in those weeks prior to the floods to give out antiretroviral medication for longer to patients because of the floods. And that's proactive action. And with 6-month dispensation now being implemented because of the funding cuts, not because of it, but being sped up because of that, that is all in all a good strategy for climate change as well, because it gives you treatment for longer. And if there's a flood in between in that treatment, your chances of having treatment is, of course, then much higher than not having it.
Thank you, Mia. Alfred, anything that you're seeing in terms of women-led efforts to adapt?
All right, so I mean, I'm just gonna use one example. There's been a lot of conversation around reusable pad, eco-friendly sanitary pad, and the role of women to advocate for that. I mean, in Nigeria and in other part of so I have a project in Uganda around menstrual hygiene management, and which is So one of the things we've been able to do is to enhance women's orientation around reusable part. So and of course, beyond the production of reusable part, there's been a lot of conversation around cutting down tax on menstrual hygiene management kits. And these are conversations that are led by women. And these are the reasons why in Nigeria, I think all through last month and this month, there's been conversation around having more women in the parliament, in legislative arm of government, either in the Senate, in the House of Rep. And the reason for this is because we really want to have more women representatives to speak for the women, to advocate for the women, if it's on climate change, I mean, whatever the issues that more women can stand for themselves, speak truth to power, advocate, and, make tangible contribution in rooms where issues like this have been discussed. So those are the two, examples around menstrual hygiene management kits, the tax relief, and of course, pushing for more women to be able to speak, advocate, and lend their voices to all of this intervention that affects women specifically. Yeah.
Thanks, Alfred. I'd like to return to the issues of of poverty and economic justice that you, Ben, and others have raised. Of course, this is another kind of macro trend in addition to climate change that has, provided the context for the withdrawal of aid. And if we take a country like Malawi, where you are a political leader, Ben, this is a country that owes billions of dollars in external debt, where debt makes up a great majority of your gross domestic product. You alluded to this before, but could you elaborate a bit on how this impacts upon Malawi's ability to withstand a shock as significant as a kind of unplanned, unannounced withdrawal of development assistance for health?
Thank you very much. To put it into perspective, I want to bring the following to your attention. Number one is the size of our GDP. Number two is where we sit now. Our debt stress level as a country is at 92%, 8 short of default. That makes us to be unbankable. We cannot borrow anymore. Therefore, any sort of withdrawal like this, which was not considerable, which was not in any way around, it was the wholesale without considering country A, country B, puts us at a very awkward position. And for me, I call it injustice, economic injustice, when it comes particularly in the healthy issues. Yes, it is taxpayers' money. We do not have a right to, we understand, but we thought a systematic withdrawal would have been deployed than an blunt one. If we were told, for example, USA will be withdrawing aid in the next year, in the next 2 years, it would have helped us to prepare. That said, it is not our money. So we've got little or nothing that we can say. We are in a situation where we are, and as a government, we must do all we can to make sure that our people don't die. We must make sure that we provide services to our people. That is why we are now deploying different measures. One of the things that we have done in Eastern and Southern African team, we have put together a team of policymakers that will be knocking on the doors of the US and other headquarters to try and do a debt restructuring or a debt relief, for a simple reason that whatever we are saving should be directed towards health for our local funding. I'll tell you this, the three biggest consumers of our foreign currency in Malawi, which has led to our failure to procure drugs, to procure fuel, to the extent that we've got a lot of queues of fuel, which makes it difficult for patients to travel from one hospital to the other, deliveries of everything. We cannot get essentials done. There are three that consumes our forex big time. Number one are drugs. Number one, I should say, is debt. We are heavily in debt to the extent that every time we pay off our debt, we are depleting our foreign reserve. As a result, it is affecting us when we want to import. Number two are drugs. Because we don't manufacture them locally, we will have to import them, and it consumes a lot. And then fuel. Now, what we're saying is immediately we do this debt restructuring, and if we can get this from our partners, we want to allocate these resources to our own local fund, healthy financing, to make sure that this is done. But it is an injustice. I really, really do not have any kind words. I know it's a law. It's a call for us as leaders to do better. But I thought it was important for a systematic sort of withdrawal with proper timelines for us to get prepared and have these shocks mitigated. But where we stand now, we have now begun to deploy what we're calling health levels. I mean, we are a new government, not so new. Where will be savers within the fuel, so that at least then it can help us to get into this health sector. We have removed the schools as well as examination fees for primary and secondary to make sure that we keep a girl child in school for as long as 1 to 18, which is the recommended age for childbearing. And as we keep them in school, we will try and put a register to make sure no parent keeps a kid at school, at home, without any reason, since the government is paying for it. That way, we believe we would manage rapid population growth, thereby managing the rest of it. So we are trying our best, but injustice, yes, that has been, and it is. Thank you.
Thank you very much, Ben. And your comments are instigating some lively contributions in the chat about issues of economic justice and injustice. Alfred and Mia, I'd love to invite you to weigh in on the debt and economic justice question, if you wish, whether you, for example, see this withdrawal of aid opening up a different kind of conversation about debt relief, so that African governments can be can fund their health systems more independently. Alfred?
Okay, so thank you, Jonathan. I think the most important thing, we've talked about this when we started this conversation. The most important thing is to see beyond the negativity or the negative impact of the cuts. I mean, the entire cut. It was sudden. We weren't preparing for this. It has been predicted. I mean, several times. We just need to close our eyes to understand that. I mean, it's going to happen, and now it's happened. So one of the things I think we should be looking at right now is how best can we maximize the opportunity within. How do we develop our industry? I mean, how do we invest on trade? How do we see potential collaboration with other sister countries? How do we bring in more investment that earns the the entire system. I mean, and this is not just about the health system. I mean, USAID funding a lot of education projects, peace and security projects, and so many conflict resolution, and so many other projects. So how do we sit down and re-strategize as government, as continent, to say, what do we have to fund what this has affected, right? So do we really have some investment strategy that allows us to get profits to fund other things that this has affected? So a lot of thinking needs to be heard. A lot of strategies we need to. You know, I started my conversation, Jonathan, by saying there is a reality that has dawned on everybody. And we need to wake up to that reality and understand that we, in our quest to want to say, oh, it's fair, it's not fair, it's happened. So I'm just thinking out loud that investment is going to be very important. And how do we manage profits? How do we cut governance? I mean, the running of governance in Africa and the entire system has been so high. I mean, most of our government guys are just enjoying. I mean, when they go to Europe, they go to come to America, they just spend our money on things that are not really relevant. So how do we cut down government expenses to fund health-related projects and programs and initiatives? How do we fund medications? How do we, either, I mean, for HIV, if it's antiretroviral drugs, how do we invest more? How do we bring in more companies that will produce vaccine? How do we train our citizens? I mean, the young people within the each of the countries to be more effective in science research, in innovations and inventions, and so many of these things. I think that is going to work best, coupled with investment, coupled with debt relief and other things.
Thanks, Alfred. Mia, any thoughts from your side on the debt relief question?
Jonathan, I pretty much agree with what everyone has said, but just maybe in summary, the US government stopping its funding didn't stay with the US government. It's pretty much changed and triggered a lot of other funding cuts. So the golden era of development funding globally is pretty much over in the way that we knew it. So the big goal is to help domestic governments to fund their own health efforts. And debt relief is certainly one way of doing that, because if you have a very small budget left after you've paid such large amounts and installments in debt relief, it becomes impossible for you to sustain your domestic health response. But in addition to that, I think we're going to see increasingly with the funding that's left from, some from government, some from philanthropic organizations, we're going to see co-funding agreements where local governments are going to be required to co-invest in those grants. And over time, we're going to see the donor proportion decrease and the domestic proportion increase. That's going to be part of those donor agreements. And I see there's a lot of chatting in the chat section about investment. And I agree with that. Investments in local manufacturing. We know that local manufacturing is often more expensive in the short term than importing generic drugs from India, for instance. So we need investment for the long term. That's a better strategy for Africa. But we need investments to make that possible. And I think the announcement we saw during UNGA about investment, it wasn't in African companies, it was in Indian companies, but the investment to bring down the price of lenacapavir, the anti-HIV injection that you take every 6 months, for Africa, so that governments are more likely to be able to afford it. That's a good thing. That's a better investment than saying we just pay for the injections for you. So in the long term, smart investments should be part of this plan.
So again, Mia, while you have the floor, question for you as well as for Alfred and Ben, invite you to come in as well. I think, in terms of adaptations, the two strategies that I think we've heard today that probably have the greatest potential to bring in large amounts of money would be resource mobilization from African governments themselves, as well as private investment. Of course, philanthropy is always going to play a role, but millions of dollars in philanthropy is never going to make up for billions, if not trillions of dollars in aid. But I would assume that the big money is going to come from either domestic governments, notwithstanding the debt question, and private investment. Wondering if you agree with that, and if so, wondering what perhaps unintended consequences or risks you see for public health and for health equity, and for access to healthcare for the most marginalized in society if we shift towards reliance on the private sector and on national governments. Mia, would you like to start with that?
Sure. So I think while this type of strategy will take a few years to a decade at least to show effect. And while you do that, there obviously would be consequences for the populations that are affected, for the populations that aren't being served well while you implement that longer term strategy. And in South Africa, we have already seen that. We've seen key populations such as sex workers and transgender people and injecting drug users. We've seen data where there is quite significant decreases in uptake of HIV testing and uptake of HIV treatment. So the risks have to do with those populations that would have been served. But in South Africa, we have seen private local philanthropy organizations making some investments. We CSI parts of companies investing in health now, and they previously would not have invested in health. They had other areas, but it hasn't been significant within the context of those large US government investments. So some of the arguments are, can't we look at HIV and see that the private healthcare sector can work with the public healthcare sector, which in South Africa are two different worlds. Our public sector serves 86% of the population, the private sector serves the rest of the population, and they serve very different populations, not just in terms of wealth, but in terms of what kind of diseases they get. So I have my doubts that the private sector would, for instance, invest in HIV, because HIV is not a big issue in the private sector. And our HIV pandemic in the private healthcare sector pretty much looks the way that it looks in Western countries. It would be men who have sex with men, and it would be transgender middle-class people, where in the public sector, it would largely be young African women between the ages of 15 and 24 who get newly infected. Those are the infections in South Africa that we really want to address. So in my country, if it comes to HIV, we need to see which private entities are prepared to invest in that population specifically, not in the small populations of the private healthcare sector. And I would think if the private healthcare sector wants to invest, they want some sort of benefit for their own populations. And I'm interested to see how that divide will be bridged when it comes to co-investments.
Thanks, Mia. Alfred, any comments on that?
All right, so I'm just going to point out some few things that I mean, this conversation is very interesting, and one of the things I've seen, like you mentioned, Jonathan, is the fact that we are looking inward. I mean, either it's domestic funding, investments, debt relief, and all that. But the risks are so much. Let me just highlight a few. One of the things we are really going to experience is the replication of initiative is going to be affected. And if we largely depend on, I talked about funding diversification, right? So either it's coming from EU, either it's coming from Global Fund, Gavi, it's still not going to be sustainable. We should try as much as possible to avoid any further future shock that is going to come. I mean, Global Fund is going to wake up one day and say, oh, I'm no longer giving you funding. What happens? We're back to USAID saga, right? So Gavi is going to wake up one day and say, oh, we are not going to give you funding. So I think the domestic investment is very important. Another thing which is also a risk for maybe when we are looking at corporate settings, I mean, corporate social responsibility, a lot of these corporate organizations have goals, they have mission, they have vision, they have things they're really interested in. And like May mentioned, I mean, corporate organization can have target audience that are not really going to be the same target audience that you've been working with before. So what happened to people you're working with before? So we're going to neglect those audience completely, and it's still going to defeat what we aspire to gain, right? So that is also very important. And I think one of the things I've also seen that is going to be a risk is compliance failure, right? So if you're working with EU organization, their compliance techniques is completely different from USAID, completely different from UNICEF, completely different from Gavi, completely different from Gate Foundation. So how do we balance that? How do we set a balance to that? So the solutions, I mean, what seems like a solution for me is just for us to have a long time strategy, have a long time goal to be able to annex domestic opportunities. And maybe when we do that, we are able to say, okay, we have this XYZ amount to take care of this social issue, and no target audience is going to left behind. The underserved is they're going to continue to benefit. And I mean, everybody is still going to be an inclusive intervention, and there's not going to be discrimination because it's coming from corporates, because it's coming from EU, because it's coming from any other body, right? Thank you.
Thank you, Alfred. Also want to thank participants for your comments in the chat that get to what I'm trying to get at with some of the risks of increased private investment in terms of health equity. Let's go to some audience questions. We've had a few. There are a couple of more that I want to put to our panelists before I ask a final question to all of you. One of them is just a factual question. If any of you are able to put this into context of the billions of dollars that the United States allocated to health assistance on the continent, how much of it actually reached your countries? Are you aware of the percentage that actually was put into health programs as opposed to being deducted in the by the overhead costs and the administrative costs of the US-based organizations that were funded to implement the programs? Does any of you have a rough estimate of that for our audience?
All right, probably let me try to dive in. That did help Malawi a bit through all these programs that they were doing. In terms of percentage, I may not really have it handy, but I know that we had a lot of people that were employed on the ground. Hence, in my preamble, I did talk about a robust community health structures that are on the ground. Those were really established with that assistance on increasing the numbers. So I should say that, yes, I know I may not have the number, but those are the kind of initiatives that we probably would like or would have loved to see. This is your exit package. Within this exit package, tell us what do you want to implement within. So we'll put system together, we'll put human resource together, we would put quite a number together. So yes, in the case of Malawi, that helped. To what extent in terms of percentage, I wouldn't provide, but I can comment, I can guarantee that it really went a long way, and as Malawi, we benefited. Thank you.
Great. Thank you, Ben. Let's put another audience question out there. If I understand correctly, this question has to do with the longstanding practice of Africans going to medical school, studying medicine outside the continent, in the United States, in Europe, and Australia. And now we're starting, of course, to see restrictions on immigration, on student visas, on universities' ability to recruit international students, including our own university at the University of Southern California. It's a bit early to tell, but can you predict that this might have a knock-on effect on the strengthening of health systems in Africa if your aspiring doctors are not able to study in the United States? Any thoughts on that?
Jonathan, I'm not sure I have a very clear answer, but what I can say is that in South Africa, the situation is complex. So we have excellent medical schools, so it's not needed to go and study elsewhere. The problem comes in with our students who mostly go to public universities. All the medical schools in South Africa are from public universities. So there's a large government investment in the training of those students, and they then leave to either work in the private sector, which serves like 15% of the country, or they go and very often work in the United Kingdom because there are similar health systems, or our training is accepted there. And one of the strategies that the government implemented to have some return on investment was to make it legally, to make it a legal rule, that if you qualify as a doctor in South Africa, you have to do community service. So you have to work in the country for 2 years before you can leave, so that there's some return on investment. But now, with budget cuts, we are, and money having to go elsewhere, we are facing a situation where the government cannot afford to pay those community service doctors. And in South Africa, a public doctor gets a pretty good salary. You know, they're not underpaid like in many other African countries. So now we're in a situation where we have money that has to be spread to more areas. And this part of the budget, which has been problematic even before the Trump administration's cuts, now will be even more affected. The government is currently considering to relook at that policy and not necessarily make it an obligation. They haven't announced what they would do, but they have announced that they will be relooking at that policy. So it becomes complex. I do think that if it's harder to go to other countries, at least there should be some payoff here in my country in any way with more doctors. But the thing is, where will they go? Will they go to the public sector where they most need it? Or will they be in the wealthy private sector where it's easy to make a lot of money as a doctor? We have a law for universal access to healthcare called the National Health Insurance. It's highly controversial, and there are lots of court cases against it, so it will take some time to roll out. But if that system comes through, and if it's well managed, and if there are some changes to the Act where there are concerns with it, then we may see private and public doctors working in the same system.
Ben, did you want to come in on that? Your microphone is off, or shall we go to the next question?
Let me get down. One thing that we must understand is that all our countries are sovereign states, and they are entitled to their own programming systems and everything that they want. Unfortunately, we live in a global village. We've got we depend on each other quite a lot. I think that these restrictions as well, in a way, have got a challenge. I'll give you a good example. When I want to travel from Malawi to the US moment, I must put a bond of $10,000 to the for me to get a visa. I'll tell you what, I don't have, my country don't have Forex, and they don't want it in a local currency. They want it in a foreign currency. The question is, where am I going to get that money? Now, fields like the health area, these essential areas where when pandemics comes, for example, COVID comes in and other related pandemics outbreaks, we share notes. And we've got doctors that want to learn from others. And when we begin to put restrictions wholesale, we are creating a problem. But that said, I believe they've got a right to do that. Thank you.
Thank you, Ben, and thank you, Mia, also for contextualizing this within the issue of what people actually do with their medical degree and the equity issues that arise. So, just one more question for all of you. Alfred, I'll start with you. Then we'll go to Mia, and we'll conclude with you, Ben. You commented on this a bit already, but I just want to give each of you an opportunity, one more opportunity, to comment on this idea that there might be opportunity in crisis. There has been published commentary about the opportunity to quote unquote build back better from this sudden shock. One of you already today referred to this as a blessing in disguise. A number of the adaptation strategies you pointed to, I think, point to, trying to make the most of a difficult situation. What is your a final reflection that you have on that? And perhaps if there is one positive development or particular adaptation that you're keeping an eye on, that you're seeing come out of this, that you think it's important for this largely Washington-based audience to follow, to monitor, to help see through, what might that be? So Alfred, let's start with you.
All right, so thank you, Jonathan. So this is very interesting. To all of this conversation, we need to talk about the way forward. I mean, we've talked about a bit of the problems, and now it's time to talk about the way forward. So in my articles that you read, I don't know if you noticed one of the points I raised there, strengthening regional collaboration, which is very important now. The conversation around what can Africa Union do? What can Africa CDC do? The AFDB, the Afrexim we need to restructure all of this conversation to see what can we do. And I think a few days ago in Ongar, the Africa CDC got a bit of funding from the UK government. And that has really helped them to maybe want to expand on the way they are funding their projects, which is still not sustainable. But I mean, our institution needs to wake up. Either Africa Development Bank, the African Union in its entity, the sub-regional unions that are, managing different regions within the continent needs to wake up. That's the number one thing that needs. I mean, there's one thing that we need to talk about, and another thing is. Yeah, you said, I mean, mentioning one example or instances, I think this is a wake-up call that has really pointed government attention to develop private healthcare units of every country, right? So we've now seen a lot of investment in primary health care. We've seen a lot of investment in tertiary health care, and that has now, and not just investment, so there are a bit of relief to say if you have this, maybe a terminal disease, or you need a surgery on some of this infection or something, it's going to come free. You're not going to pay XYZ amount again. It's free, interventions are now free. So these are things we really want to see. Government needs to come back and restructure each of our countries within the continent, invest in real health facility, make equipment available, invest in equipment, which is very important. The reason why you see some of our top government guys coming to the US, to the UK for health tourism, it's because there is no equipment. And of course, we've talked about the personnel, the migration of the personnel, but if there are lots of equipment that can house technical experts in the continent, our personnel will stay back. But when we don't have equipment to house our technical experts, they're going to go to somewhere. I mean, they will have to get a place to work. And of course, their welfare is also very important. So these are conversations that has really springs up. And government is trying a bit to see if they're able to manage well. But I think if there's something to monitor from your end, the primary health care facilities will be one of the best to monitor and to oversee in years to come. Thank you.
Thank you. Mia?
Jonathan, you know, one of my favorite quotes about the funding crisis is one of Mitchell Warren, who heads up AVAC in New York. And he always says that, you know, when you've had an earthquake, which essentially is what this funding crisis is, when you build buildings afterwards, you don't build them in the same way. You build them in a way that they are resilient or more resilient to an earthquake. So you can't have in the funding crisis the same health system. You need to build something different. Now, of course, we've spoken before about the crisis that has sped up a lot of solutions. But if there's one solution that I would hope this crisis also speeds up, it is resilient systems against corruption. Because whether you have debt relief or whether you have domestic funding, it's all affected if the money doesn't end up where it's supposed to go. And I would hope that if that is something that we build stronger systems around, it's not just health that's going to benefit, it's the entire countries, it's education, all the departments that will benefit. And if we can fix that, you know, in South Africa, we had a huge report that was released by our special investigating unit today. And just at one hospital in Johannesburg called Bhekisisa Hospital, there was $12 million of corruption. That's just one public hospital. Can you imagine if we save those amounts of money and it goes towards where it should be going? And I think part of corruption fighting would be to get proper follow-up in place for whistleblowers who get killed or who get targeted, so that there's protection for people who speak up against it.
Thank you so much, Mia. We will definitely keep an eye on whether those resilient systems against corruption begin to emerge out of this earthquake. Thank you, and Alfred, thank you too for all of your comments today. Ben, what are your final thoughts on this question?
Thank you very much. It's unfortunate that as Africa, we have been an accident waiting to happen. You cannot have leaders that only depend on aid, because no country has ever developed using aid. We didn't see it coming. I wish we did. We didn't plan for it. Unfortunately, it's in. We must smell the coffee and move forward. We must remember this is taxpayers' money. And because it is taxpayers' money, donor fatigue shall always remain. One day, the EU shall say, bye-bye. The UK shall say the same. If we can't wake up now, then we shall never wake up. We shall die. What we need to do, therefore, is that we need to be innovative enough, enhance our low resource mobilization, have the healthy insurances in place, close our wastage taps, and the savings be allocated prudently. We must wake up and begin to establish drug and commodity manufacturing companies within our region and trade among ourselves, because we can always discuss on the trade imbalances. We can look at somebody's deficiencies and be able to aid each other, and payment modes can be deployed. African scientists and researchers must wake up and come in and aid, provide evidence to governments We are lawmakers, we are policymakers. We need evidence that really should help us in policy framing and resource distribution for us to get better. In closing, I would like to say, time for wastage, time for corruption, time has now elapsed. It's time for us to pull our sleeves, close those taps, and help ourselves, as it looks like there is no more room for help. Thank you very much.
Thank you very, very much, Ben. And please join me in thanking all of our incredible panelists today. That concludes this part of the program. I hope you'll stay for the final 15 to 20 minutes of today's program, where together with Adam Clayton Powell III and Judy Keck, we have the honor of inaugurating our first cohort of USC Global Senior Fellows in Global Health Communication Leadership. This is a brand new program that is a collaboration of the USC Institute on Inequalities in Global Health and the Center on Communication Leadership and Policy, which is part of our Annenberg School for Communication and for Journalism and Communication. It's the first year of this fellowship program. We have selected 4 inaugural fellows, all of them from Africa, who will be using innovative communication and journalism strategies to amplify a neglected public health issue of their choosing. 2 of those fellows you've already heard from, 2 of them you're about to hear from. We will ask the 4 fellows to please turn on your cameras if you can, and give you an opportunity just to introduce yourself, where you're from, and the project that you'll be doing during your fellowship year. Perhaps we'll start with Jepchirchir Kiplagat, and then move to Yewande Alimi, and then back to Ben Phiri, and then Mia Malan. Before we invite our fellows to introduce themselves, I just want to ask if Adam or Judy wants to say any words about the new program.
We really look forward to this new program. Special welcome to Mia, Ben, and all of our new USC Health Communication Fellows. And also special thanks to Jonathan Cohen, not only for his moderating today's discussion, but also for his leadership creating and then persuading our USC colleagues to fund the USC Health Communication Leadership Program. So with that, let me turn it back to Jonathan.
Thank you, Adam. So I'm sure you'd rather hear from the fellows themselves than hear from me. So let us begin with Dr. Jepchirchir Kiplagat.
Great. Thank you so much, Jonathan. Can you hear me?
Yes.
Awesome. Thank you. My name is Jepchirchir Kiplagat from Kenya. I'm a lecturer at Moi University School of Public Health and a public health expert specializing in health systems research and epidemiology. I'm also a researcher at the academic model providing access to healthcare. That's the AMPATH program. AMPATH is a consortium of or a partnership between Moi University in Kenya, Moi Teaching and Referral Hospital as well in Kenya, and a consortium of about 18 medical centers spread across the US and also Europe. I am doing research within AMPATH focusing on using implementation science to enhance care delivery for older people living with HIV. So that's me, and hopefully I can introduce a bit of the project that I'm doing within this fellowship. So my project really is titled Reframing Aging with HIV, Communication Leadership Initiative to Elevate the Voices and the Rights of Older People Living with HIV in Sub-Saharan Africa. It's a project that seeks to elevate the voices visibility, and also the rights of older people living with HIV, with a focus specifically in Kenya. What we are hoping is that as you know, older people living with HIV grow, and their growth really is attributed to, one, increased life expectancy on ART, and two, also ongoing acquisition of HIV at older age, that despite this increase in numbers in older people living with HIV, the population continues to remain largely absent from public health narratives and also even from policy priorities. And they face a lot of, challenges, including stigma, social isolation, and even health system barriers that fail to address, complexities related to HIV, NCD, and aging in general. So we are hoping to use this project in a strategic way, using right-based communication to challenge, ageism and discrimination, stigmatizing narratives that we often hear among older people living with HIV, by amplifying lived experiences through participatory storytelling and translating these insights into targeted advocacy for age and HIV responsive policies and services. Our hope is that we can leverage human-centered design. These are the implementation science approaches to accessible platforms, or rather using the accessible platforms like radios, like WhatsApps, and engage older adults as champions themselves, with the hope that we can be able to shift public perceptions, foster empathy, and also drive policy change towards, dignified, inclusive, and holistic care for older people living with HIV. So we are out there answering the question, how can strategic communication and narrative change influence public perceptions, reduce stigma, and promote the rights of older people living with HIV in sub-Saharan Africa? Thank you so much. That's a bit about my project and myself. Appreciate a lot for the opportunity of being in this fellowship. Thanks a lot. Over to you.
Thank you. Thank you very much, Jip Churcher, and we're so pleased and honored to have you in this cohort. Let us turn to Dr. Yewande Alimi to introduce yourself and your project.
Thank you very much, Jonathan, and good afternoon, morning, depending on where you're connecting from. My name is Wande Alimi. I'm the One Health Unit Lead at Africa Centers for Disease Control and Prevention. I have a decade experience in health policy and diplomacy, but primarily my focus has really been around One Health governance and implementation. At Africa CDC, I primarily lead a lot of the One Health work that we do on antimicrobial resistance, zoonotic diseases, food safety, and most importantly, climate change, which really nicely transitions me to talk a bit about the project that I would be focused on during my fellowship. It's been such a fantastic privilege, but most importantly, as you can see, my colleagues in the cohort also bring in unique experiences which our continent truly needs. And I'm really hoping that all four of us can really shape and really serve as the building blocks of strategic communication around some of these pertinent global health related issues. Primarily, my project is going to focus on strengthening strategic communications for climate health resilience in Africa. And I'd say it's very timely, given some of the very I'd say igniting comments that have come out from the UN General Assembly, where the climate change a reality which Africa suffers the highest brunt. Ladies and gentlemen, Africa contributes the least amount of greenhouse gas emissions, but our country suffers the highest brunt when you think about climate and health. A few things that have come out in the conversations ongoing is that climate change is something that a few people are familiar with, but when you start to think about the impact of climate change and health, it becomes a distant reality, even for us as technical experts. So primarily, this project is is aimed to bridge that critical gap between climate science, health impact, policy, and citizen action by helping us in Africa to develop a bit of a culturally relevant communication model that applies to our setting. This project will primarily explore and try to design a bit of innovative storytelling and advocacy tools that can help elevate African-led narratives on the health impact of climate change, particularly with a focus on gendered impact and community engagement. I think overall, when I'm done with this particular project, one of the things that I would hope that this can answer is how communication strategies can be designed to help Africans understand and act on health impact of climate change. Ideally, we'll take on an approach that where we can develop intentional messages, identify the right platform, but most importantly, also understand the timing of how the messages can go out. We'll try to also do a bit of audience selection in such a way that we can look across the policy experts, civil society groups, as well as youth networks to really drive the awareness, political will, and citizen participation on this particular topic. So thank you very much, and back to you, Jonathan.
Thank you, Yewande, for that fantastic introduction and overview. Our next two fellows you've heard from on today's panel, but you haven't had an opportunity to hear them introduce themselves and the project that they'll be working on for this particular fellowship. So let's begin with Ben Phiri. Over to you.
Thank you very much, Jonathan, and the rest of the audience. My name, as introduced, I'm Ben Phiri. I am a member of Parliament and former Minister of Local Government and Rural Development. I am the President or Chair of the Eastern and Southern African Parliamentary Caucuses on Sexual Reproductive Health and Population. I have been involved a lot in the area of sexual reproductive health and rights and issues of population across our region. I am part of this inaugural cohort, and my project looks at communication barriers or challenges in the Eastern and Southern African region, particularly in the highly sensitive culturally as well as religious areas. We in this project are looking at quite a lot of investment that has been done, particularly in this particular region, in as far as what it is and so much but the impact thereafter has not been as expected. Huge sums of money, for example, have been invested in the areas of reproductive health, but very little has been registered. A good case in study is that of Malawi, where rapid population growth has affected sexual reproductive health, HIV/AIDS, as well as the environment. But what has caused the same? Because tools, communication tools, have been put in place, and so much has been put in place. You will find that most of the tools are not and should never be one size fits all. Now, in these highly sensitive cultural and religious areas across our region follows the same pattern. You will find that there is a lot of stigma in these very areas. You will find that in the commodities, for example, you'll find that you've got a lot of drugs within there, a lot of commodities, but they expire because they cannot be used because of stigma. Now, with what we are experiencing now of donor withdrawal, particularly from the US, one has to dive down. We therefore want to dive down by looking at the already established tools in literature review, by engaging different focus groups to look at why and how the tools that have been there have not been that very effective. Again, what are most of the challenges that have been established? By the end of the day, we tend to establish tools that are tailor-made for specifically these highly sensitive religious as well as cultural regions to make sure that every resource that gets there has got an impact and it's effective on the ground to reduce wastage, to reduce cost. It will help us to reduce stigma. At the same time, it will be able to help us manage the rapid population growth, which increases of social services for our people, to making sure that we've got a better place to be. So we will deploy whatever in our project, both qualitative as well as quantitative, to make sure that we leave no stone unturned. And within our focus groups, we'll be talking to the cultural leaders themselves. We'll be talking to the religious leaders themselves. We'll be talking to the youth. We'll be talking to those affected, like those affected direct and indirectly, to make sure that the tool that we establish really gets down to arrest the challenges that we have, as we can no longer afford to have wastage in already affected area resource-wise, and in an Africa that cannot provide services to its people. So generally, that's what we'll be looking at. And by the end of the day, the tool will be in place. Thank you very much.
Thank you very much, Ben. And last but not least, Mia Malan, over to you to introduce yourself and your project for the fellowship.
Thank you, Jonathan. I am Mia from South Africa, and I'm a journalist. And I head up a non-profit organization, a media organization called the Bhekisisa Center for Health Journalism. Bhekisisa is a word in the largest language of my country, isiZulu, and it means to look at something closely or to scrutinize it. So when a Zulu patient goes to the doctor and wants to be checked out really well, they will ask the doctor to Bhekisisa them. And we, about 2 years ago, launched a very specific focus on climate health at Bhekisisa. And because it's such a significant issue in Africa, and as Yewande has so eloquently pointed out, it's so important that we have African voices when it comes to the health effects of climate change in Africa. So my project will build on 2 projects that we already have at Bhekisisa. It's donor-funded projects by the Wellcome Trust that will look at stories around climate health, but very much within the fashion of how the media has changed. And one of those changes is that media is no longer just about print stories on websites, but it's very much about social media. And what we see at the moment still is very much a print story, that of which a different version is then done on, for instance, Instagram on a reel form. We want to swing that around a little bit and use the reels to do print stories with. So part of my project is to produce Instagram reels on those health effects of climate change that we don't often talk about, such as the effects on HIV, on TB, on diseases like diabetes, and its mental health effects. So we'll do a range of Instagram reels, not me alone, our reporters, on that, with very much also possible solutions that some countries have implemented that our government can learn from. And then we will also do a webinar specifically on the mental health effects of climate change, and also a TV program. We have a monthly television program on a national station in South Africa. So in October, that program will actually come out. And all these things together, we hope would have an effect. We'll use those reels to also do a big print story about and insert those reels to build the print story around those reels instead of the other way around. Thanks, Jonathan.
Thank you, Mia, and thank you, Ben and Yewande and Jep Chirchir. Congratulations, and we're so glad that this program affords you an opportunity to work on these highly impactful projects. And with that, I have the privilege of turning it back to Adam Powell to conclude our program today.
Thank you, Jonathan, and special thanks to all of our new USC Health Communication Leadership Fellows. We look forward to seeing you, visa issues permitting, here in Washington, D.C. and in Los Angeles early next year. And of course, we'll be in touch and see you by video individually and together many times between now and then. Today's discussion actually brought a quote from 6 decades ago to mind. It has often been said that Africa is poor. What nonsense. It is not Africa that is poor. It is the Africans. Those are the words of Kwame Nkrumah 65 years ago, after he became the leader of the first African colony, then called Gold Coast, to achieve independence. That's Ghana. When Nkrumah said that, the GDP per capita in Africa was 1/6 of the global per capita GDP. Today, Africa's GDP has fallen to a much smaller fraction, mainly because of a surge of wealth in Asia. Nkrumah and other African leaders found and find it difficult to build sustainable economic growth, and so much flows from this, with healthcare front and center. There's little discussion today of US or European health aid to China. China was a poor country 60 years ago. 60 years ago, Korea had a smaller GDP per capita than many African countries. As Ben Phiri said today, no country has developed with aid. Alfred Akerele just described it as a wake-up call. Malan talked about the challenge of corruption. We've heard today in chat from Richard America, from Johnson et Pair, from Hippolyte Kofak, and others about this underlying fundamental issue and how it can be addressed. This brings to mind another quote from the early 1960s. We do not do these things because they're easy. We do them because they are hard. That was John F. Kennedy challenging American engineers to build the Apollo spacecraft to go to the moon and return safely. They did that. This is, if anything, a much larger challenge, and we'll do it, not because it's easy, but because it's hard. Our next Africa-U.S. forum will be Monday, October 27th at the same time. We look forward to seeing you then. Until then, we're adjourned.